afternoon, everyone. Mei Ling here. Today I'll be presenting a case-based discussion with the title of A Dose of Blue Rescue, whether it is life-saving or whether it serves as a last resort therapy. So the content of my presentation, first I'll be going through a case which we manage in HTA. And following that, I'll be talking briefly on vasoplegic shock and the role of IV methylene blue and what are the evidences available in adult as well as in peds critical care site and some learning points from the case. So so last month, we had this girl who is with the name of Ni. She actually is a 12-year-old girl with a weight of 28 kilo. So a little bit of background information on her. She has underlying supracellular GCT germ cell tumor, which was being diagnosed last year December. So with that, she actually completed her chemotherapy and radiotherapy in July this year. So apart from the brain tumor, it was also complicated with central diabetes insipidus with panhypopituitarism, whereby she was on regular thyroxine, hydrocortisone, as well as desmopressin at home. And following the course of the chemotherapy, she also had the issue of hypophosphatemia attributed to the ifosfamide-induced renal tubulopathy. So she came to us on 10th of September with the presenting symptoms of having vomiting at home for the past 4 days, whereby she had these episodes of vomiting each and every time after she ate. Yeah, and with that, she could not tolerate orally as well. So besides that, she also complained of having a fever for the past 2 days. And on the day of presentation, she appeared to be more lethargic compared to usual. But despite being unwell at home, she's still taking her and not tolerating orally well. She's still taking her desmopressin every day, and her hydrocortisone dose was not being increased to the stress dose at home. Yeah, so what happened is when she reached to our emergency department, okay, so upon review and assessed by the emergency team, she was alert with full GCS, but she appeared lethargic and she was having a prolonged capillary refill time of 3 seconds with coolish peripheries. Pulse volume was small. She was hypotensive with tachycardia up to 155. Her saturation was hovering on 90% on air. And she was febrile as well, with the temperature documented to be 38 degree. Her sugar done was 4.5. But otherwise, her systemic examinations was unremarkable. And following that, there was some investigation results being available. Her total weight was 15, non-neutropenic. HB was 12.4, platelet was 170. Her renal profile showed, sorry, it's a typo. Her renal profile showed raised urea of 12, sodium of 136, potassium 3.6, creatinine was actually 41. Venous blood gas showed decompensated metabolic acidosis with a lactate of 4.3. So tying the clinical findings together with the investigation result, she was being diagnosed with non-neutropenic sepsis in decompensated shock. And on top of that, we also have to, there's also a differential diagnosis of whether this is an adrenal crisis, considering that she has been on a prolonged steroid maintenance at home. Yeah, but what does not point towards that is that the electrolytes, the sodium and potassium was still normal, and sugar was okay. Yep. So the emergency team, they did a good job. So they actually supported her with a nasal prong oxygen 2 liter. She was being resuscitated with fluid boluses, okay, using a crystalloid of normal saline up to 35 ml per kilo. And she was also being started on no adrenaline infusions up to 0.3 mic per kilo per minute. And since she's in a septic shock, so antibiotic was promptly given as well.
Mm.
And the antibiotic of choice was meropenem. And besides that, the stress dose of IV hydrocortisone, 2 milligram per kilo, was also being served immediately. So, upon reassessment, she remained lethargic, but hemodynamically wise, she improved, okay, with a capillary refill time of less than 2 seconds, with good pulse volume. Her blood pressure also picked up, and less tachycardic with the fluid boluses and the supportive measure. So she was then being arranged and admitted to our PITS ICU. And here is the timeline summarizing the sequence of event happened in PITS ICU. So on the first day of admission, her BP, her blood pressure was rather labile with tachycardia. Again, she was found to have a poor pulse volume. And with that, we resuscitated her with fluid boluses using colloid plasmonic albumin, 20 ml per kilo. And in viewing of her presentation of having a recurrent vomiting, gastrointestinal losses, so she was then started on full maintenance and also a correction drip of 10% over 24 hours. For the next 4 days, she was then being treated for septic shock due to pneumonia. On the next day of admission, she developed worsening respiratory distress with low bowel saturation. She also appeared to be more confused as compared to before. Okay, and with that, we needed to secure her airway. Yeah, and the X-ray showed left lower zone collapse. So she was then being ventilated using a conventional ventilation. Okay, needing the FiO2 requirement of up to 60%, highest pressure requirement up to 25 over 8. And for the first 3 days, actually her condition became more stable. We managed to wean off or inotrope. But during this period of time, we did have difficulty in adjusting her fluid balances, mainly because she has underlying DI, central DI, and there is a lot of adjustment needed to adjust her fluid balances using intermittent desmopressin or furosemide infusion. And following that, okay, on day 6 of admission, which was on 16th of September, whereby early in the morning at 2 o'clock, again, she suddenly developed a new onset of hypotension, whereby she was found to be hypotensive with a BP of 47 over 28, heart rate of 99, and the pulse pressure variation that time was 13 to 15%. So the on-call team needed to resuscitate her again using a colloid, 10 ml per kilo, for a total of 3 doses. And following that, she remained to be hypotensive, needing to be started back on inotropic support, okay, requiring up to 3 inotropic support. And the septic workup was then repeated, and the IV meropenem was being continued, and IV amikacin was also added on. And at this point of time, the working diagnosis is a septic shock. Yeah, uh, yep, septic shock. So apart from that, her condition further deteriorated, whereby she also developed severe ARDS, needing increased ventilation support. with the OI rising from 14 up to 37, FiO2 requirement up to 100%. Yeah. And she also developed acute kidney injury, coagulopathy, lactic acidosis with the highest lactic being 14, needed to be supported on CRT. So despite ongoing resuscitation and management, her condition further deteriorated, whereby we had difficulty to oxygenate and to ventilate her lung. So she was being changed to HFOV, yeah, needing an MAP up to 28, yeah, and FiO2 up to 100%. And her condition did not improve. She remained hypotensive, and repeated echo was done, and she was found to have a diastolic dysfunction, whereby we needed to add on Mivrinone for the diastolic dysfunction. And at this point of time, her hydrocortisone was being changed to methylprednisolone, considering that she has severe ARDS at this moment. Yeah, and her antibiotic was also being adjusted as the blood culture, the prelim report came back as MDR or Acinetobacter baumannii. Yeah, so she was then being treated with IV polymyxin B and unacin, also added on antifungal fluconazole. And at this point of time, we then consider the role of IV methylene blue, whereby 2 milligram per kilo loading was being given. Actually, this was being given after 24 hours of the septic shock. Yeah. So this is the point where we serve the IV methylene blue. And what we can see is that there's no significant improvement in terms of the hemodynamic parameters. And again, over here we can see that the her urine color also become blue-green in color. Yeah. And these were her X-ray taken on admission. Yeah, a small heart with hyperinflation of bilateral lung field. And this is the chest X-ray captured on the day of demise, whereby both lungs were consolidated with effusion. Yeah, severe ARDS. Yep. So, and she then succumbed on day 7 of admission, and with the cause of death of severe Acinetobacter sepsis with multi-organ failure. And that I would like to bring on two main discussion points, which is the number one is the vasoplegic shock, and number two is the role of IV methylene blue. So, talking about vasoplegic shock, vasoplegia is defined as abnormally low peripheral systemic vascular resistance, whereby there is loss of the peripheral vasomotor tone, which manifests as profound hypotension in an acute circulatory failure state, or there's the requirement of vasoactive vasopressor therapies to avoid the hypotension. And on top of that, there is the presence of a normal or increased cardiac output. Okay, so in other words, it also is known as refractory vasodilatory or catecholamine resistant shock, whereby the shock is not the vasodilatory shock is not responding to the fluid boluses or vasopressor anymore. Yeah. So again, this definition of vasoplegia is rather variable, and in which there's no consensus definition on this. But in the adult ICU, they do define it when they do define it as when the mean arterial pressure is less than 65 millimeter mercury. Okay, and the number two is that the vasopressor dose requirement of at least 0.2 to 0.5 microgram per kilo per minute of noradrenaline or equivalent or more. And also the normal and or the normal or increased cardiac output is being defined as the calculation of the cardiac index of at least 2.2 to 2.5. And some study also calculate the systemic vascular resistance index of less than 800. Yeah. So again, the causes of vasoplegic shock it can be variable as well as what being listed here. But for our pediatric population, the common causes would be due to sepsis, number one, and also those who undergo cardiac surgery with cardiopulmonary bypass. Yeah. And next, what I'd like to highlight is that this diagram actually it represents the a spectrum of the common clinical conditions which can lead to vasoplegic shock. Okay, and it depends on the nature of the trigger. Okay, ranging from having an infection, a sepsis, to a sterile injuries, and also to the non-immune causes. So on the left here, we have sepsis, which is actually a classical example of systemic inflammation driven by the PAMS, which is the pathogen-associated molecular patterns. Yeah, whereby for sepsis, these microbial molecules or parts, right? It will actually activate the pattern recognition receptors on our immune cells, and then it will trigger a lot of the release of the pro-inflammatory cytokine, leading to the systemic inflammation and systemic vasodilation. And as we move towards the middle of the spectrum, we can see that, for example, the major surgery, pancreatitis, polytrauma, or burns. So these are the conditions whereby they are not infective in nature, but in fact they are the sterile. They are considered as the sterile inflammation. Yeah, whereby without infection, it is still able and capable to cause a lot of systemic inflammations. Okay, while these DAMs, which is the damage associated molecular patterns, yeah, which is the whereby the cellular or the tissue damage, it actually release all these DAMs, and these DAMs also similarly it can activate the immune receptors and causing a lot of SIRS and cytokine storm, leading to vasoplegia. Yeah. And again, on the far right here, we have those clinical conditions like drugs, anaphylaxis, or neurogenic shock, which are non-immune mediated. And yet all these clinical conditions they can actually cause the end result, which is the same, the vasoplegia, the loss of the vascular tone. Yep. So I find this diagram very simplified and easy to understand, whereby this diagram can actually explain very well the pathophysiology for vasoplegic shock, the four main mechanisms in causing this. So of course, the primary pathology in vasoplegic shock is the vasodilatation, which is the loss of the vascular tone, causing a profound vasodilatation. And again, in sepsis, because of our dysregulation of our immune system in reacting to the infection, it causes a lot of release of the inflammatory cytokines, right? And these inflammatory cytokines will actually stimulate the production of the nitric oxide. And this nitric oxide actually is the main driver of vasodilatation. Yeah. So, and of course, besides that, this nitric oxide, it also will actually cause the activation of these potassium ATP channels on our vascular smooth muscle cells, okay, and causing the hyperpolarization of the membrane. So what happens is that the membrane remain to be in a hyperpolarized state, then the smooth muscle will not be will be in a relaxed state. Yeah, so it won't be able to contract. So that's why it contribute to the vasodilatation. Yeah. Second mechanism is that it involves the vascular hyperresponsiveness. Okay, whereby in cases of in the event of sepsis, septic shock. Okay, there is a lot of the high circulating endogenous catecholamine, right, which are the adrenaline, noradrenaline, angiotensin 2. Okay, and all these catecholamine will then lead to the desensitization and also the downregulation of the receptor responsible for this hormone. So with that, uh, since the receptors are being downregulated, so then they are not so responsive anymore to the exogenous catecholamine, which means they are not so responsive to our exogenous inotropic support. Yeah, this will explain why vascular hyperresponsiveness can happen. Also, the vasopressin, which is being released from our posterior pituitary, okay, in response to hypovolemia, okay, and it will cause the store in the posterior pituitary to be depleted of this vasopressin, so that when the septic shock persists, then there will be a reduced release of the endogenous vasopressin. Yep. So the third main mechanism is the capillary leakage, okay, whereby the systemic inflammation, all these cytokines, it will cause the endothelial dysfunction and the shading of the glycocalyx, which is the gel-like layer in our inner layer of our endothelium, okay, and it's being disrupted. The glycocalyx is being shredded and disrupted. So with that, there will be a lot the translocation of the plasma, the protein, being leaked out from the vessel into the extravascular space. Yeah. Also, there's a lot of the disruption and damage on the endothelial connection, the tight junction. Okay, and with that, it will with all the activation of the platelet, the coagulation cascade, okay, and with the glycocalyx shading, and all this will actually prone to microthrombus formation, and with this, it will lead to tissue hypoxia, and this is what we call it microcirculatory failure or dysfunction. Yeah. So understanding this pathophysiology is important because this will then help in guiding the treatment strategy in tackling the vasoplegic shock, which we call it a multimodal strategy. Okay, whereby we combine the usage of the inotropic support, vasopressin, okay, and also we also explore on the role of methylene blue, which act as a inhibitor of this nitric oxide in impeding and stopping the vasodilatation. Yep. So with that, I'll move to the second part of my presentation, which is on this methylene blue. Yeah, a little bit history on this methylene blue. So it is being first discovered as a synthetic dye in the textile industry. Yeah, by a German scientist back in 1876. Okay, basically it's a dye used in cotton fabric. Then few years later on, back in 1880, then this methylene blue is being discovered and identified to be used as a medical stain, okay, and in our histopathologic and microbiologic specimen. And also, it is being recognized as an anti-malaria treatment during that point of time as well. And then subsequently, we start using the methylene blue in surgical procedure to stain those tissues and to track those sentinel lymph node, okay, especially in cases in the surgery of a mastectomy or the parathyroid surgery. And later on, it is also being discovered to be beneficial in treating septic shock. And in the year of 2016, okay, it is being approved by the FDA as the treatment for methemoglobinemia. Yep. So how does this methylene blue help in treating vasoplegic shock? So, just to revise back on the pathophysiology of the vasoplegic shock, okay? With the with with the presence of the all those inflammatory mediators, it actually will activate this nitric oxide synthase, the enzyme, to convert the L-arginine and to form this nitric oxide. Yeah, and not only this, these inflammatory mediators will also activate a lot of those inducible nitric oxide synthase. Yeah, and then hence it will lead to a lot of the nitric oxide being produced, and this will cause the vasodilation. And this nitric oxide will also activate the soluble guanine cyclase enzyme. And then this enzyme will cause the dephosphorylation of this GTP to this cyclic GMP. And then and this will be a secondary messenger in augmenting and creating more vasodilation of the smooth muscle cells. So the role of the methylene blue is that it will actually inhibit this nitric oxide synthase, both the endothelial form and also the inducible form. And then hence this will stop the production of the nitric oxide. Yeah. And apart from that, methylene blue will also inhibit the guanylate cyclase activation in the vascular smooth muscle cell, and then this will also cause vasoconstriction, yeah, rather than vasodilatation. So, based on our KKM medicine formulary, the methylene blue available in Malaysia are in two concentration, be it 0.5% or 1%. And it is being recognized as the treatment for idiopathic as well as for drug-induced methemoglobinemia. And these are the recommended dose. Okay. So how about in HTA KL? So we have this form of methylene blue, okay, the proof blue, which is the 0.5%. It's a 5 milligram per mil, okay, and 1 ampule there's it actually has 10 mil, and we have 5 ampule, and actually it's not expensive. The price of each ampule actually it costs about 65 ringgit for each ampule lah. Yeah, just for your interest. And this is our protocol on using methylene blue for patients in septic shock, which I'll elaborate further. So this is the dose suggestion. So for neonate and children, okay, the recommended dose is 1 milligram per kilo over an hour, okay? And it can be followed by an infusion of 0.25 milligram per kilo per hour, or we can give it a higher dose of 2 milligram per kilo stat over an hour, and we can repeat it when necessary. Okay, yeah. And it can be given in an undiluted or diluted form. Okay, and if we want to dilute, we have to dilute with the D5% solution, because it is not compatible with the normal saline, because the chloride ions in the normal saline, it will reduce the solubility of the methylene blue. Okay, so and this methylene blue is rather stable at the room temperature, and after dilution, we have to immediately use it, and it is rather photosensitive as well. We have to make sure that it's fully protected from the light source. Yeah. And this is another dose recommendation by this Starship Child Health. Uh, the recommended dose, bolus dose, is about 1 to 2 milligram per kilo over 5 to 10 minutes. But in cases of severe renal failure, then it's recommended to use 1 milligram per kilo. Okay, and they consider the efficacy, means good response, if there's more than 10% reduction in the other vasopressor infusion rate. Yep, after 60 minutes. Yep. And if let's say there's no response or poor response, then we can actually repeat the dose after 60 minutes. Yeah, either a bolus, repeated bolus dose or infusion. Yep. So of course, before we use it, we have to make sure that we know the contraindications of using it. Okay, those who has known hypersensitivity to the active substance. Okay, those with severe renal impairment. But this is according to the leaflet of the medication. But we do consider giving methylene blue in cases of severe renal impairment because most of the time they are rather ill critically and supported with CRT. Yeah. And always check on patients' G6PD status, okay, before giving it because it can cause acute hemolysis if they are G6PD deficient. Okay, it is also contraindicated in cases of methemoglobinemia due to chlorate poisoning or treatment of cyanide poisoning. Okay, and these are the list of common side effects of methylene blue administration. Okay, after giving it, it's normal to have a blue-green discoloration of the urine, the feces, and the skin. Okay, there's also the risk of hypersensitivity and anaphylaxis, risk of hypotension or arrhythmia. Okay, for those with G6PD deficiency, the risk of acute hemolysis is there. Okay, for those who is on antidepressant SSRI, the risk of having serotonin syndrome is there, since methylene blue is also an inhibitor of monoamine oxidase. Okay, for those with pulmonary hypertension, you need to be watchful on worsening pulmonary hypertension. Yeah, since it's a vasoconstrictor, right? Yeah. And for those infants less than 3 months old, the risk of a rebound methemoglobinemia is there. Yeah. So, as what being mentioned earlier, the only FDA approved indications of using methylene blue is for the treatment of methemoglobinemia. But other than that, it is being off-label use in conditions of a refractory vasoplegic shock, eye phosphamide-induced encephalopathy, be it treatment or prophylaxis, and also treatment of hepatopulmonary syndrome. Yeah, in cases of end-stage liver failure. So, what are the evidences available then in using this methylene blue in treating refractory vasoplegic shock? So, this is actually a study, a randomized control trial done in Mexico back in 2023. Basically, they look at the early adjunctive methylene blue usage in adult patients, this in adult population, in adult patients with septic shock. Basically, they recruited a total of 91 patients, and for the treatment group, what they give is that they actually infuse the methylene blue every day for a total of 3 doses, means 3 days. And they gave a fixed dose of 100 milligram in 1 pint of a normal saline. Yeah, over 6 hours every day for 3 days consecutively. Yeah, and with that, they found that the time to vasopressor discontinuation actually is shorter in the treatment group for as compared to the control group. Okay. Similarly, the time to the vasopressor free days at 28 days also is shorter. Okay, by 1 day. And for those treated with methylene blue, they also found to have a lower cumulative fluid balance at 4 days, whereby they have lesser fluid balance of 740 ml. Yeah. And in terms of the ICU stay, they also have a shorter ICU stay by 1.5 days. And similarly for the hospital length of stay, they also had a shorter hospital length of stay. But on the other hand, in terms of the serum lactate and the mortality rate at 28 days, actually there's no difference for both the treatment and the control group. Yeah. Next is on this systematic review and meta-analysis on methylene blue in sepsis and septic shock. This is also being performed on the adult patients. Okay, basically, this included three paper, and all these three paper are all RCT paper. But and actually, this included the study which I shared earlier. Yeah, but the other two are rather small study whereby they only included a total patients of 20 and 30 lah. Yeah, and what we can see that is that for the intervention group, they give a dose of methylene blue 2 milligram per kilo bolus, followed by an infusion, a stepwise increment in the rate, yeah, and maintain for 1 hour. And for the second study, they also give a continuous infusion for 6 hours. Yep. And what they found is that those treated with methylene blue actually it's associated with reduced days on mechanical days, a lower length of ICU stay, as well as less time to vasopressor discontinuation. Yeah. So what about the mortality rate? Yeah. Again, there's this systematic review and meta-analysis done by Chong et al. On efficacy and safety of methylene blue, also in adult population. And the pool data show that those treated with methylene blue, they had a significantly reduced mortality. Yeah, with an odds ratio of 0.54. And during this study, there's no serious side effect found. So they concluded that it is safe and effective. Yep. So what about pediatric population then? Actually, I only managed to find two paper. First is on this methylene blue used in pediatric by Rachel Moss et al. So actually, it's a retrospective observational study in which they look back those cases treated with methylene blue, and they actually included a total of 33 cases, and half of the cases they used the methylene blue due to vasoplegic shock. Okay, whereby the remaining half is for the purpose of surgical dye and also methemoglobinemia. And during this retrospective review, there's no patient being found to experience any serious side effect, which included the hemolytic anemia or serotonin syndrome. But what they found is that the VIS score improved in 4 out of 18 cases at 1 hour. The mean arterial pressure, the systolic blood pressure all will improve at 1 hour. So they actually concluded that methylene blue may be safely considered as a rescue therapy in vasoplegic shock. Next is this systematic review and survey practice analysis on methylene blue usage for refractory shock in children. So this systematic review, it included a total of 24 studies, but majority of the studies are case report, 17 case reports, 4 case series, 2 cohort study, and only 1 RCT. But this RCT is on patients with heart lesion repair and after cardiopulmonary bypass. So from this review, they actually included a total of 102 patients, less than 25 years old with refractory shock, and all due to different etiologies. Yep. And all the study, they actually reported improvement in the mean arterial pressure and ability to win the inotropic support. And out of the 13 case report, the median vasoactive inotrope score before the methylene blue administration was 80. And after administration of the methylene blue, it came down to 4.5, the score, and it is significantly lower. And the time point for the VIS score calculation, actually, it ranged from 10 minutes to 14 hours. So with this, they actually concluded that methylene blue appears safe and it may benefit children with refractory shock. And second part of this review is that they also do a survey practice analysis to look at the knowledge and the practice pattern of US-based pediatric intensivists. What are their knowledge and practice pattern of methylene blue? But the response rate from them was only 23%. Yeah. And they found that up to 40% of the intensivists, they reported that they used methylene blue before. And similarly, about 40% of them also never even consider using methylene blue for the purpose of refractory shock. And the common reasons listed for not using methylene blue is because they are not familiar with the drug. They are not sure about the proper dosing, and most importantly, there's lack of solid evidence to support the benefit of it. So, coming to the last slide. So, I think the learning points from the my presentation and the case is that I think understanding on the four main mechanism of vasoplesic shock is rather important in guiding us on managing it accordingly using a multimodal strategy. And just to remind, yeah, methylene blue is a selective nitric oxide inhibitor, and get to know and be familiar with it. And we shall consider to start and to use the methylene blue early in cases of vasodilatory shock. Yeah, with that, I thank you for your attention.
Thanks a lot, Mei-Ling, for this systematic and comprehensive review of methylene blue. Yeah, now can I open the floor for any question to Mei-Ling?
Hi.
Sue, yeah, Sue.
Yeah, Sue here. So how many of y'all use this? I just want to run a bit like a survey here and see how many actually use it.
So I'm using it.
How often do you end up having to use it, and how early do you use it?
You see, for those that have more than 200 trope and then still have sign of vasodilation, like warm and very high perfusion. I mean, perfusion is very good and warm and low diastolic pressure. Then I'll consider. Yeah.
And usually how many hours into the shock already by the time that you consider this?
It depends. I mean, it's like, so like after 200 trope, he still appear warm and short, then I will give. Yeah. I mean, especially the time that I use is that when they're still clinically perfusing well, but then the BP not there, and then low diastolic pressure after 200 trope, then I will give. Yeah. The 200 trope include one vasopressor, like a NOAD. Yeah.
That means most of the patients you would do this. How often do you need to like in 1 month? In 1 month, how many times do you have to do it?
1 month. Last month I used once for one of my oncology patient who presented with a Klebsiella pneumonia in shock. Yeah. The one that after 200 trope, then still not work. Then only a methylpred. Yeah.
I mean, I try to use this in my patient here, and not been really successful. I think yesterday I tried to, no, not yesterday, day before yesterday, I used it on an ECMO patient. I mean, the ECMO patient is still there, but it is not, I didn't, you use only a single 1 hour infusion, or you put it over 12 hours or so?
My practice is 2 dose, maximum 2 doses. Sometimes I go to 3rd dose if they're still like vasodilate. Yeah. So first dose, then after that follow by half an
1 hour infusion.
Yeah, 1 hour or sometimes half an hour, depending on how's the condition. Like sometimes I run for half an hour to 1 hour. Yeah. Then wait for half an hour to 1 hour. It doesn't work, then I give the second dose. Most of the time, after second dose doesn't work, then usually it might work already. It might not work anymore. Yeah. But at times, so if it's still very vasodilate, then I will give the 3rd dose. Yeah.
Yeah, I think I used it uh before. I think this is probably only the fourth time I tried to use it, but
Yeah.
in the all the three cases that I use, maybe it's a bit late also because all the other things are all quite maximum already. Then
Right. Right.
only think about using this. And then of course, even when I used it within that 1 hour of infusion,
Mm.
I don't see much dramatic difference in the blood pressure.
Yeah. It must
All
be.
the three cases
Yeah.
also like that. One was a very small kit. I
Mm.
think 1 or 2 months ago, I
Mm.
used for a 3 kilo kit. I
Mm.
used twice, once on one day, didn't see much difference. Then the
Mm.
following day, I try again.
Mm.
Also, no, not much difference.
It,
Uh,
mm.
so I don't know lah. The experience not very good.
But it must be a warm shock. It
Mm.
must be a quite classical warm shock. That
I, I
yeah.
I mean in my ICU a lot of them are all the temperature cannot be very reliable
Mm.
in
Mm.
terms of my patient here. So I
Mm.
can only look at the monitor and look at
Okay.
my
Right.
diastolic pressure and my
Okay. Mm.
overall blood pressure. So by the time we come to this, usually inotropes are very high as well as
Mm.
the blood pressure very low.
Mm.
Or maybe if I try very, very early, I don't know lah. But so far not very good.
I see. Okay. Now, how are
The
the
others,
rest?
the
Uh,
others.
yeah.
Hi, Pon here. Can you hear me?
Yeah. Yeah. On it.
Hi. We also do use, but of course, only those refractory cases,
Mm.
like something like what Chaw has been doing, also 1 or 2 doses. Of course, some patient doesn't really work, but we do see some successful usage in some of the patient.
Mm.
Actually, I have a question for Mei Ling. Mei Ling, I might have not able to follow some of your slide, but what are the evidence of vasopagic shock in this patient that you've seen in your patient?
Yeah, actually, for my case, I think it's rather late. It's rather late for us to consider using it because by the time we use it, it's already more than 24 hours from the shock. Yeah. And when we give that time, because the patient is already on high vasopressor dose, so actually there's clinically there's no evidence of uh vasodilatation. Means the actually in fact the pulse pressure is rather narrow, and on top of that, the patient's heart also is contractility is also very poor already. Yeah, which could be due to the sepsis as well. Yeah. Mm.
Meaning,
So
maybe you can show back the time point that you gave the methylene blue, the vitals chart.
okay.
Yeah, that's why I want to ask Dr. Cho, the time point from the time the fellow developed the shock, poor blood pressure till the time you start your methylene blue,
Mm.
how long has that been?
How long, huh? So as I say, I depending on the patients. If there's warm, I mean, is the limbs are still flush and warm, despite all two of my inotrope,
No, I
then
mean
I
since they admitted already, is 1 day later or is it in the same day already you started using the methylene blue?
like for example, the oncology patients that I used the other day. So he turned ill in the morning. So after the resusc initiation, by late morning, I started the Methylene Blue. Yeah,
All right.
yeah.
The other cases also the same.
Uh, I can't really remember, but most of the time, these are the scenario.
Means very early lah.
Uh, yeah, they
Because
are
mine
type.
also
Mm.
mine also more than a day later when I see ayo tak boleh lah. Don't know what else to do lah. Then only use lah.
Yeah, but the main thing is that it must be a vasopagic shock. It must be a warm. The telltale sign of those patients that I could see respond is that usually, despite inotropic support, they are still warm and very good perfusion and low diastolic pressure. So for those that are cold one, then I mean, although they're fever, but the tissue perfusion are cold, then usually they they might not work that well. But at time also, I use it after multiple inotropic support. Then I just want to try and then just give a dose or two and just try. Yeah. So those are the scenario that sometimes can happen. Yeah. But the one that we tried for the last oncology patient, he did improve quite a lot after the one dose only Methylene Blue. Then subsequently the inotropic support managed to stabilize and wind down the next day. But he have a Klebsiella pneumonia, septicemia. Yeah.
Thanks.
Yeah. Okay.
I suspect so that it's not starting late. I think it really depends on how sick the patient actually is. I mean, just like Charles said, I have to say we here in Likas also experience with Methylene Blue is not great. When you read the literature, it almost sounds as though it's like the silver bullet. The evidence seems to be skewed pretty one way. It's so miraculous and all that. And when we tried using it a few times, yes, actually the initial blood pressure is very miraculous. It's also so miraculous that you almost want to pat yourself on the back, but the BP cannot hold. So you give it the 1 milligram or 2 milligrams per kilo, the BP bumps up. It's so miraculous. Everybody is there staring at the screen and blinking a few times to see whether it's really true or not. But then after that, after the infusion wears off, within half an hour, you see the thing starting to sag. And then within 1 hour, you are almost back to the same blood pressure before your Methylene Blue. And by the second hour, you are below again. So the two times that we were successful, like Charles said, they were okay. One was septic, and then the other one was DKA with sepsis on CVVH also. But their heart contractility was strong. And their inotropes were not terribly high. Adrenaline norad maybe 0.4, 0.4 or 0.3, 0.4. But just like Mei Ling's presentation, I realized that the ones that I use on the adrenaline norad, you're talking 0.6, 0.7, it doesn't make a difference. I think it really depends on the sickness of the patient. So the ones that failed also reflect Mei Ling's case. You get a bump up in the blood pressure from before you start, you're talking about maybe 80-40 or 70-30. Suddenly you give the Methylene Blue, the guy goes up to 120 by 70. It's that miraculous, but after that, it cannot maintain. So I usually give a bolus, and then after that, I maintain the infusion because the ones that were successful were maintained with an infusion. But I find that the ones that died also cannot. It just won't work. So I think it's more sickness than illness severity than the timing, because all the sick ones we started on day one itself, it didn't work also. But all the ones that didn't work, when you did the echo, after what you already noticed that the heart contractility is so poor, and the perfusion is actually like what Charles said, is really crappy. Even though you got low diastolic, which actually tells you that there's a degree of vasoplegia happening there, but it's really community acquired kind of cold shock, not the warm shock that you see from oncology kind of patients.
Yeah, thanks.
Yeah, because do agree with Chun Wen. It's probably not so much of the timing. It's actually like whether the child is in vasoplegia, because from the vital signs that Mei Ling you're showing, you can see the diastolic is actually quite high, and there's actually quite narrow pulse pressure as well. And I also learned that your patient has some poor contractility that you needed to start on. So if the child is having a poor contractility with a lot of vasoconstriction, so Methylene Blue may not offer benefit. In fact, the concern is whether we are increasing too much of the afterload and the heart cannot pump because of the poor contractility. So you probably have to be quite selective on which type of patient that we are trying to start the Methylene Blue, because most of the time we all agree that first your heart has to be pumping not too bad. It may be affected a little bit, but by the time you start Miron, then the contractility has to improve. Otherwise, it really may not able to cope with the surge of the afterload after you started the Methylene Blue. And the child has to be actually vasodilated and not vasoconstricted. Then they may not add benefit to I mean, the hemodynamic status lah. That's my personal view on this patient. Yeah.
Any other question?
Lily got a question. Mainly I want to ask if patients on extracorporeal, any dose adjustment needed?
I think based on my literature review, I think no dose adjustment is needed.
One more question to everybody, because there's limited data, no RCT in pediatric population, so we are off-label using methylene. Will anyone take consent for it, or how would you talk about this?
Tak ada. Just give aja. For me, it's like part of the inotrope. Yeah.
Yeah, okay, thanks.
Anyone take consent or not? I mean,
I didn't use to until the last case that failed. It was a staphylococcal scalded skin lah. So it was very low diastolic. But high contractility was a bit what, but we were desperate, and so we used it. But so if any one of you have this sort of staphylococcal scalded skin, you're thinking of using, I think it's probably worth taking the consent, because although the side effects always say that you got bluish skin and all that, but previously we didn't see. But in this very young child, yes, and the child didn't just turn blue. The child actually turned a little bit grayish.
Oh.
And finally, when the child passed away, it was very horrible to see. And the parents were a little bit shocked. So ever since then, I take consent.
Okay.
Because I don't want to run into this. But I know this is not so much a problem with the bigger kids.
Yeah.
But I think the smaller kids with a thinner skin, and if your skin is shedding, I think you really got to think a few times, because you might lose the child, and then after that the body that the parents take back look really not nice.
Okay.
Yeah.
Good point. Thanks.
The only thing is, usually when we need to use methylene blue, it's kind of an emergency because the child is crushing the baby. And I mean, the difficulty is whether you could get the parents, and whether the parents is, I mean, come in time for you to take the consent before the patient die. So I find it sometimes a bit difficult, especially for life-saving purposes. Yeah. To get the consent. But of course, if parents are just beside you, maybe it's just kind of just explaining to them you need to start this drug because of the the life-saving and emergency situation, and kind of like what the children say, explain to them that the child could have shown some the effects of the drugs. But I think to take a written consent, I don't know. What do you think? Is it possible?
I will normally take a verbal consent, because when I ask for GCPD status, so at the same time I will just take the consent. I mean, verbally, I just inform them the potential things that they might see when the urine turn green color. I think everybody was shocked. So verbally tell them when I actually ask about the GCPD status, when I'm confirmed, I will give them. I will actually just tell them, but no written.
Hello,
Hi.
Can I ask? So I was thinking about this consent thing for quite some time. What do you all think about getting informed consent for all the patients admitted to ICU, for emergency and life-threatening conditions and treatment and management, so that when they first admitted to PICU, we get the informed consent for emergency and life-threatening management. So I'm not sure. What do you guys think?
Yeah, my adult colleague is practicing it in the adult ICU. So when they admit, then there will be a consent taken for. I mean, that cover all the procedure. But I have yet practiced it. I'm not sure the rest have practiced or not.
Well, in cases like this, like Dr. Pon said that, there's not enough time, then we need to give the medication as soon as possible, not enough time to talk to the parents. So whether we should actually get the informed consent earlier on when they're on admission.
Anis, you mean we list down all the treatment, or you just in general we will do whatever that save life?
For emergency and life-threatening. Only for emergency and life-threatening management and treatment.
So we do not list down lah, just say emergency
No,
and
yeah.
life save.
Yeah, so
Yeah.
Anis, what do you want to cover?
Because like what now we are talking about just now, like, you know, some certain things
But
might
you
not.
wouldn't think about it yet, you know?
Yeah, but there are some ICUs actually doing this upon admission when they do the orientation for the ward, for the ICU and all. So they get informed consent for any procedures or treatment that is a emergency and life-threatening. So I was just asking everyone whether do you think that is actually something useful?
ICU, I mean, IGN has blood transfusion and IV access consent that we take on admission to the ICU. Just to tell them that, we will invariably end up setting invasive lines for you, as well as transfusing your kit. But we don't cover other things lah, because in case the fella got other complication, I don't know what to tell them yet.
Yeah, but it's like a macam life-threatening emergency lah. But I've seen a few informed consent on that. Then I was talking to the management team, the quality, and then we are still talking about whether it should be done or not lah. So just wanting to hear everyone's opinion.
Hello, hi.
Yeah.
This is Yuan here.
Mm.
So usually for life-threatening procedure, under the MMC Council, no consent. Actually, we no need to take consent. We just perform the procedure. But if you think that the procedure is not not life-saving, then you basically all the things you do, including the medication, that kind of thing, you need to tell them. You need to tell them what is the indications. Is there any alternative? That kind of things. So for example, if like during emergency, you need a IV access. So you want to set the central line. So the central line is considered life-saving procedure. Then you no need to take the consent. But after some time, if you think that the child already stable already with the peripheral line, but you want to insert the central line, then the central line is actually you need to get the informed consent, because it's a procedure that you do on the patients. So there's a general principle.
Dr. Chow, what about since methylene blue is off-label use and not inside the blue book indication for sepsis, could we apply through the KPK, through the Ketua Pengarah Kesihatan about the usage of methylene blue in sepsis as a general for the PITS ICU? Or is it need to be requested by by hospital basis? Because this was the question when we want to start methylene blue, because over here in HTA, they are very evidence-based and they really ask about all the details and about this informed consent. Yes, we always tell them. But what one of my pharmacy suggests is this KPK request, because it seems that we have been using a lot of medication without not as per blue book indication. So like the off-label use. So what about this?
Siwa, you have any idea on this in terms of law? Yeah.
Okay. So so a lot of medication is off-label use, but okay. So for example, you want to start methylene blue. There are literature state that is useful. So that is considered evidence for you already. As in you can start based on the literature. Then you also have to inform the parents. So what I usually do is this one literature show that is effective, but there's not much data in children. We usually use the data extrapolate from the adult. but in adult it's proven to be useful, so we want to use it. Then see what usually when the child like want to die already, they will follow, but eventually you still need to communicate with them. It's not like then you say that these medications is the benefit is outweigh the risk, like risk of hypertension, that kind of thing, but it's useful, that kind of things. So you explain, basically explain if the complications happen. So all those medical legal thing happen is always due to poor communication. So for example, we said the outline turn, the limbs turn gangrene, that kind of things. So parents want to sue us, that kind of thing. But at the beginning, so for example, you want to set the outline, you need to you tell the parents, okay, so we are setting the outline because of this. We want to reduce the number of booking. We want to monitor the blood pressure because of started inotrope, that kind of thing. So what is the benefit of having this? Without this, then we cannot monitor properly. But doing this procedure is not without the complication. There's a risk of this. So if in the event that these complication happens, what are the measures that we can do? But you cannot like totally abolish the complication because everything we do definitely have complication. Just that you need to communicate, like that, lor. So because if anything, if the complication never communicate before, then the parents will say that, oh, you never tell me. If I knew that this will happen, I would, or I die also, I wouldn't let you insert the outline in this patient, that kind of things. So you do something, because you warn them already, we foresee this complication. So then this one become a sad decision already. So I think it's useful. Parents, I told you already, so we proceed, that kind of things.
Okay.
So it's like that.
Okay.
So you apply the KPK item, it doesn't apply the KPK, I think it's only for you to buy the drugs only. It doesn't really cover you anything. Yeah.
So our experience, thanks you. Our experience here is last time when I first start to use, then I asked my pharmacy to go and look for evidence. So they did help me to look for evidence, then we were able to use it subsequently without much problem. Yeah. The pharmacy will cure it. Yeah. But then I put the question to them, then I asked them to look for evidence. So that's why they make the protocol for me as well. So they are the one that make the protocol for me. So from there, then it is basically a mutual understanding. It's off-label use, but it can be used. Yeah. Does that answer your question, am I right? Maybe you can ask your pharmacy to draft out a protocol for you. Yeah, based on their reading. Since there are also some guideline from other center, like one of the guideline like mailing share, so you can share that guideline with them, so that they also understand that other center have been using it. Yeah, it's just that the drug is readily available, especially for make hemoglobin. It's just that if you want to use it for hypertension, sometimes you find a bit resistant. Yeah. So that is another trick. I ask them to do and then draft the protocol for you. Okay. I think it's about time for us to stop already. Thank you very much, Mei-Ling, for this really good presentations and very systematic and comprehensive. You don't mind to upload it into the system? Yeah. Okay. Thanks a lot, everyone. Thanks for all your input. All right. Okay. All right. Bye, everyone.
Okay, thank you,
Thank
everyone.
you.
All right.